Now let us move on to the principles of drugs binding to receptors. First, we have intermolecular forces. Drug molecules in the environment of receptors are attracted initially by relatively long-range electrostatic forces. Then, if the molecule is suitably shaped to fit closely to the binding site of the receptor, hydrogen bonds and van der Waals forces briefly bind the drug to the receptor. Irreversible antagonists bind to receptors with strong covalent bonds. Then we look at the affinity of the drug. This is a measure of how avidly a drug binds to its receptor. It is characterized by the equilibrium dissociation constant, denoted as Kd, which is the ratio of rate constants for the reverse, K-1, and forward, K+1, reactions between the drug and the receptor. The reciprocal of Kd is called the affinity constant, Ka, and in the absence of receptor reserve, which we will talk about ahead, is the concentration of drug that produces 50% of the maximum response. It is now important to talk about antagonists. Most antagonists are drugs that bind to receptors but do not activate them. They may be competitive or irreversible. Competitive antagonists bind reversibly with receptors, and the tissue response can be returned to normal by increasing the dose of agonist, because this increases the probability of agonist-receptor collisions at the expense of antagonist-receptor collisions. The ability of higher doses of agonist to overcome the effects of the antagonist results in a parallel shift of the dose-response curve to the right, and is the hallmark of competitive antagonism. Irreversible antagonists have an effect that cannot be reversed by increasing the concentration of agonist. The only important example is phenoxybenzamine, which binds covalently with alpha-adrenoceptors. The resulting insurmountable block is valuable in the management of pheochromocytoma, a tumor that releases large amounts of epinephrine, also known as adrenaline. We have other types of antagonism as well, which are less common. Non-competitive antagonists come under this category. They do not bind to the receptor site, but act downstream to prevent the response to an agonist, like calcium channel blockers. Chemical antagonists simply bind to the active drug and inactivate it. For example, protamine abolishes the anticoagulant effect of heparin. Physiological antagonists are two agents with opposite effects that tend to cancel one another out, like prostacyclin and thromboxane A2 on platelet aggregation. Now discussing receptor reserve. In some tissues, like smooth muscle, irreversible antagonists initially shift the log-dose response curve to the right without reducing the maximum response, indicating that the maximum response can be obtained without the agonist occupying all the receptors. The excess receptors are sometimes called spare receptors, but this is a misleading term because they are of functional significance. They increase both the sensitivity and speed of a system because the concentration of drug receptor complex, and so the response, depends on the product of the agonist concentration and the total receptor concentration. Now we come to partial agonists. These are agonists that cannot elicit the same maximum response as a full agonist. The reasons for this are unknown. One suggestion is that agonism depends on the affinity of the drug receptor complex for a transducer molecule. Thus, a full agonist produces a complex with high affinity for the transducer, like in the case of coupling G proteins, whereas a partial agonist receptor complex has a lower affinity for the transducer and so cannot elicit the full response. When acting alone at receptors, partial agonists stimulate a physiological response, but they can antagonize the effects of a full agonist. This is because some of the receptors previously occupied by the full agonist become occupied by the partial agonist, which has a smaller effect, like in some beta-adrenoceptor antagonists. This brings us to intrinsic efficacy. You must be wondering, what is this? This is the ability of an agonist to alter the conformation of a receptor in such a way that it elicits a response in the system. It is defined as the affinity of the agonist-receptor complex for a transducer. A drug that is a partial agonist in a tissue with no receptor reserve may be a full agonist in a tissue possessing many spare receptors because its port efficacy can be offset by activating a larger number of receptors than that required by a full agonist. Tachyphylaxis, desensitization. Tolerance and drug resistance. When a drug is given repeatedly, its effects often decrease with time. If the decrease in effect occurs quickly within minutes, it is called tachyphylaxis or desensitization. Changes in receptors may cause desensitization, like suzamethonium. Tolerance refers to a slower decrease in response within days or weeks. Tolerance may involve increased metabolism of a drug. The examples of this would be ethanol, barbiturates, or homeostatic mechanisms. They are usually not understood, but homeostatic mechanisms gradually reduce the effect of a drug, like morphine. A decrease in receptor number or downregulation can also lead to tolerance, for an example in the case of insulin. Drug resistance is a term reserved for the loss of effect of chemotherapeutic agents. For an example, antimalarials. Keep watching ahead to learn more about how to quantify the receptors in the body, using assays and radiographic techniques.